Hello, my name is Clemens Wertendijk, and this video is recorded for Anatomy and Physiology of the Auditory and Vestibular System at Gallaudet University. I will be presenting today on the cytomegalovirus pathology, particularly as it affects the hearing mechanism. First, we will define cytomegalovirus and provide details about some of its effects both within and outside of the auditory system, as well as provide some data about acquisition and incidence. Cytomegalovirus, or CMV, is a variety of the herpes virus. This puts it in the same family as viruses like chickenpox, shingles, mononucleosis, and herpes simplex virus, which is otherwise known as just herpes. There are two key varieties of CMV, acquired and congenital. While ultimately the same virus, their symptoms and treatments can be vastly different, with congenital CMV generally presenting with a larger set of potential consequences. Of note is that the umbrella of acquired CMV includes perinatal CMV, which denotes an infection occurring either during birth or shortly after due to breastfeeding. We will discuss more about the effects of congenital versus acquired CMV, as well as pathologies they may cause or present alongside, in upcoming slides within this section. Finally, CMV affects a wide range of systems within the body. Effects on the auditory system, which will be the primary focus of much of this presentation, are just one of the large set of body systems and functions that may be interrupted or otherwise impacted. So what are some of these symptoms? Well, generally that depends on whether the infection is acquired or congenital. For otherwise healthy adults with acquired CMV, we find that symptoms are most often minimal or completely absent, aside from temporary flu-like symptoms at the time of infection. While rare, however, there is still a risk of acquired CMV causing healthy adults to develop mononucleosis. Some research suggests that this number is higher than previously believed, as CMV complications are often erroneously ruled out in immunocompetent adults, but the danger is still considerably lower in these cases. In immunocompromised adults with acquired CMV, there are more concerns and potential complications. These include, but are not limited to, retinitis, colitis, hepatitis, encephalitis, and pneumonia, but do not include hearing loss, which is not a known feature of any acquired CMV. Even congenital CMV in newborns presents with a very wide range of possibilities. What do I mean by that? Well, in about 4 out of 5 cases, a newborn with congenital CMV will experience no major long-term health problems as a result of their CMV. For that 1 of 5 who will be symptomatic, the most common symptom is sensorineural hearing loss, which may be anywhere from mild to profound and may progress through adolescence. This means that a child may appear asymptomatic at birth and pass their newborn hearing screening, but later experience gradual onset of sensorineural loss. Vestibular dysfunction, though rarer, may also arise and intensify through adolescence. In addition to hearing and vestibular concerns, a newborn may also have more easily observable and immediately dangerous symptoms, including premature birth, microcephaly, jaundice, poor liver function, pneumonia, seizures, and more. I'd like to take a moment to discuss why CMV causes sensorineural hearing loss and vestibular dysfunction, and I feel the best way to do that is to use this picture. I've adjusted the contrast and brightness to try to make these images a little clearer, and I will do my best to explain what each of them shows. Images A and B are of an infected cochlea. They are oriented differently than we're used to, and the scala media or cochlear duct appears thinner than I would anticipate, which, as far as I understand, is not directly related to the presence of CMV and may be due to the process of the histological staining. What's striking to me about these images is that we can directly observe these masses of viral material, which have been stained dark purple here, and see how they clump onto the stria vascularis and Reissner's membrane. So this demonstrates that CMV doesn't directly attack the hair cells, but instead causes them to degrade by inhibiting the cochlea's ability to produce and regulate endolymph. Figures C and D show an infected vestibule, which is admittedly more difficult for me to explain in detail. For now, I think it is appropriate to just say that the virus attacks the environment rather than the sensory elements themselves, much like in the cochlea, and leave it at that. On to acquisition and incidence. Like most herpes viruses, CMV is spread in a number of ways. The primary method of exposure is through the bodily fluids of infected people, all of which carry infectious CMV-positive agents. CMV is likely to spread through sexual contact, organ and blood transfusions, the sharing of drinks, or in the case of perinatal CMV, intrauterine fluid, or breast milk. This is arguably less relevant, but I found the policy of blood donation centers surrounding CMV to be very interesting and thought it worth sharing. All major blood donation charities will test for CMV and organize stocks of donated blood into CMV positive and negative pools. Blood from the CMV negative pools will be held for immunocompromised individuals, while the CMV positive pool can be used for all others determined to be immunocompetent. This means that for someone receiving a blood transfusion who has no known consistent underlying health problems, the blood received is likely to be CMV positive. As such, even highly regulated blood transfusions are a vector for infection. This is not a legitimate problem with the practice, of course, as the vast majority of immunocompetent adults will experience no symptoms from CMV, just something I found interesting and that you may as well. These conditions have enabled CMV to spread very effectively, resulting in an approximate 50 to 85% incidence rate by age 40. This range is so wide because most adults will never have a reason to be tested for CMV, so it remains somewhat disputed. Congenital CMV can be passed from mother to embryo at any point during the pregnancy but before birth, with earlier infections generally being associated with a higher risk of serious complications. There is an approximate 30 to 40% chance that an infant born to a mother with CMV will have congenital CMV. This results in 0.5 to 1% of children being born with congenital CMV, though this number is also disputed as currently a CMV test is not a standard element of a newborn health screening. CMV is the most common congenital infection in the US, as well as the most common non-hereditary cause of sensorineural hearing loss, accounting for approximately 1/3 of all cases of sensorineural loss in young children. In the next part, we will discuss the process of diagnosing cytomegalovirus. Please be aware that as only congenital CMV has a significant audiologic effect, it will be the focus of the remainder of the presentation. First, we will talk about diagnosis of infants who are born already presenting with rarer conditions secondary to CMV, like microcephaly, jaundice, or premature birth. In these cases, saliva and urine samples will be collected immediately and analyzed using viral culture testing or a polymerase chain reaction test, something with which we are all probably very familiar as it is the same method used in the COVID-19 nose swab test. The sample must be taken within the first 3 weeks after birth, as it becomes impossible to distinguish between a congenital and perinatal infection after this point. For infants who appear healthy but fail their newborn hearing screening, these same samples will be taken as soon as possible. The family will be referred to an audiologist or audiological clinic at which hearing loss can be confirmed or ruled out, and a confirmed sensorineural hearing loss in combination with a positive CMV test provides enough data to move on to treatment. It should be noted that this only applies to sensorineural loss, so issues such as ossicular disarticulation or an occluded canal do not suggest CMV has directly impacted hearing. To confirm hearing loss in an infant, an audiologist will generally use auditory brainstem response or ABR testing and otoacoustic emission or OAE testing. These tests are both highly useful for testing infants as they do not require any active input from the person being tested and can be conducted on a sleeping subject. Finally, for individuals with CMV who have typical hearing at birth and experience loss of hearing through adolescence, it may take longer to reach a diagnosis. The overall process is very similar, but less clear in that testing will no longer reveal whether the infection was congenital or acquired. One positive about the client being older is that a larger range of tests are considered appropriate and can aid in specifying the presence of sensorineural loss in particular, such as tympanometry, air and bone conducted audiometry, and the Rinne and Weber testing. Additionally, testing for the presence of CMV will only happen after a sensorineural hearing loss has been confirmed. This, in combination with the extra time it may take for a child or adolescent to be flagged for potential hearing loss or express concern about their own hearing, means that these cases often start treatment much later than would be optimal. That brings us to the conversation around early identification through standardized CMV screenings. Though CMV is the leading cause of non-hereditary hearing loss, it is not currently a standard part of a newborn screening. Newborns will only be tested for CMV in cases in which sensorineural hearing loss is suspected, meaning the approximate 15% of symptomatic cases where hearing loss instead develops through adolescence, as we discussed, will be missed until a voluntary follow-up. Some researchers have argued for CMV testing to be made a fixture of a typical newborn testing battery, as this would enable early identification and may greatly aid in the management of the onset of hearing loss and/or other symptoms. However, another community of researchers feels that, in most cases, this would be an undue burden on the families. This is because only 1 of 5 individuals with congenital CMV will have any long-term consequences, so parents who identify that their child has CMV may invest large sums of time and money into treating symptoms which will never actually appear. This is a complex issue, and while I lean toward the idea that identification is usually better, the arguments against it are sensible and consider the perspectives of parents who may have limited time and/or financial resources, as well as asymptomatic children who would not benefit from treatment but could be subjected to it anyway. This is an ongoing conversation within parts of the healthcare community with no immediately clear answer, but I thought it worth including. We now move on to the third and final section of this presentation, prevention and treatment. Currently, there is no known cure for cytomegalovirus. In general, preventative methods include the use of antiviral drugs to minimize viral buildup in the cochlea and vestibule. While there are a number of approved drug treatments, the primary pharmaceutical is called ganciclovir, which is delivered intravenously and operates by limiting the ability of the virus to spread and infect other cells throughout the body. There's also a variety of ganciclovir delivered orally, which is called valganciclovir. These drugs are typically effective, but it should be noted that they may also increase an individual's vulnerability to bacterial and/or fungal infections. They do have the potential to restore some lost hearing, but work more effectively as a preventative measure. Keep in mind that audiologists do not have the ability to prescribe, so if the family is interested in antiviral treatment and would like more information, we should refer them to a doctor who can determine if a prescription would be appropriate for their case. Though CMV is unique in many ways, the sensorineural loss it may cause is quite typical and should be treated in much the same way as any sensorineural hearing loss at a young age, and if pharmaceuticals were not used, not prescribed, or simply not completely successful, there may still be hearing loss present. Because the loss is often progressive, however, it is particularly important that follow-up and repeat tests are conducted often. As always, treatment of progressive hearing loss tends to be more effective the earlier it is caught. If it is important to the family that the child has access to spoken language, this likely means fitting them with a hearing aid and counseling the parents or guardians on its maintenance and use, as well as referring to a speech-language pathologist or other professional to conduct speech and language therapy, particularly for prelingual cases. For the range of ages spanning infancy to adolescence, a behind-the-ear hearing aid would generally be preferable. This is because the ear molds on BTE hearing aids can be easily replaced as a child grows, and they are considered easier and safer to handle both by the family and the child himself. For cases in which the hearing loss is severe or profound, and hearing aid usage has not proven beneficial, consideration may be given into cochlear implantation. Because CMV does not affect the vestibulocochlear nerve, this pathology alone does not preclude cochlear implants from providing access to hearing. Research has demonstrated that for CMV, and particularly in the absence of CMV-induced disorders, CIs were effective. It is important to remember that audiologists should never be the ones making this decision, only providing enough unbiased information to the parents or guardians so that they can make the most informed choice. In addition, vestibular function should be tested at each follow-up, as it may also progressively worsen. If vestibular dysfunction is confirmed, an audiologist will work as part of a balanced treatment team to rehabilitate and protect against further progression. Thank you all for watching, and I look forward to reading and responding to your comments.